Welcome back to the PFC podcast. The views and opinions you are about to hear are the speakers and do not necessarily reflect those of anyone else. Now on to the podcast.
Welcome back to the PFC podcast. This is Dennis, and today I'm with Doug. How are you doing today?
I'm awesome. Glad to be back, Dennis.
Perfect. And the reason I asked an ICU intensivist to come on is because this is actually can be pretty complicated. I would like to walk through, crush syndrome and all the ins and outs and misconceptions that come up all the time. So since it's been a hot minute since you've been on, would you mind doing just a real quick introduction of yourself?
Yeah, sure. My name's Doug. I'm a medical intensivist. I currently practice in a cardiovascular intensive care unit at West Virginia University, where we train quite a few 18 deltas and other soft medics. And I'm still in the reserves with one of the special operations commands on Fort Liberty.
Perfect. So first thing, jumping into crush syndrome, whether it be a natural disaster or a man-made one, you're entering into probably a pretty dynamic environment, probably different than most of our scenarios where you have a random heavy weight that falls on a person and there's actually nothing else wrong around the scene. So if you wouldn't mind just speaking to scene safety going into the environment.
Sure. Yeah. Crush is generally, like you say, a dynamic environment, whether it's due to, a blast and a building collapse, could be a construction site. We're deployed and we have medical assets and, there's a construction accident nearby and we're invited to help. And it definitely could be a natural disaster, as we just saw in, the big Turkish and Syrian earthquake where I think there were, 47,000 casualties. We weren't participating, but that could certainly happen in a neck of the woods where we would have forces that would respond. So yeah, all of those are dynamic. In a blast injury, you've got to be cognizant of, secondary devices that may be triggered when the rescuers respond. Construction or natural disaster, earthquake. Also, hurricane with blowdown, you've got unstable structures. And then you obviously have, casualty counts that could range from, the singletons well within your capabilities to manage to a full-blown mass cal where, you really are making some rapid triage decisions and trying to do the most for the most, not everything for everyone. Safety of the rescuers is paramount because you're not going to do anybody any good if you take casualties. And a lot of rescuers are injured, responding to the scene in whatever situation caused the injury itself.
Yeah, absolutely. I think there's one statistic everybody kind of throws out is there's 1.5 rescuers that are killed for every person that's been saved, which is a pretty depressing statistic. But just, like anything, like we always train, scene safety, pay attention to your environment. Don't just charging in and trying to save the day right off the bat. Pay attention to your environment.
Yeah. One of the other things to add too is, what's in the air, what's been released into the air by the collapsing buildings or the blast itself, and be really, really careful or keep in mind, in addition to you could be injured by a secondary explosion or a further building collapse, you could also, become a respiratory casualty pretty easily. So, have the proper ventilation protection as a rescuer. And and you may have to stand off until you get it. I mean, we saw that in 9/11, in the Twin Towers collapse. There's a lot of secondary respiratory injuries and even deaths of the rescuers years on.
Yep, absolutely. And that's just, concrete, dust from the concrete, we're not talking about, exposed electrical, piping, gases, things like that are opened up and now expose all the rescuers. So just pay attention not only to the environment, but the other rescuers around you. Just got to be super observant.
And unfortunately, we now live in an era of dirty chemical munitions, improvised chemical munitions, which just adds a layer of nastiness and complexity to a potential conflict explosion.
Yep, absolutely. So, barring scene safety and, cribbing and bracing and things like that, that's required because there's going to be a lot of resources that are needed for an event like this. Just initial assessment, does T-Tri-C still matter or?
Yeah, 1,000%. Crush casualties, crush patients are trauma patients. And, we're focusing on crush syndrome here, and I know we're going to get to that, but let's not skip over the fact that, there could be other traumatic injuries causing, overt or hidden bleeding that could make the patient unstable. So good TCCC assessment, a good primary survey, stabilize any other injuries that are life-threatening, whether they be bleeding, airway, respiratory, before you move on to free the casualty and start, potentially getting into crush syndrome.
Yeah, absolutely. The scenario doesn't care if this is too complex for whatever education level you have. You're given what you're given. It can be a crush and a TBI, a crush and a really fill in the blank.
Correct.
You still got to deal with it.
Correct. I like to say, in fact, I gave a talk earlier this week at WVU on cardiogenic shock. And my third slide, I think, was a picture of a chef. And one of my favorite sayings is that complex problems are recipes, not ingredients. And so, you really need to pay attention to all of the aspects of diagnosis and all of the aspects of management if you want, the dish that is the successful outcome for your patient to be baked successfully. To take the analogy all the way.
Yeah. And, life threats, kind of run into this question, tourniquets. Should I be putting them on early? Should I wait? He's got like a, 4,000 pound weight on him. I don't imagine my tourniquet's going to cause that much more harm.
Yeah, it's interesting. I was doing a little bit of reading for this podcast because I was one of the co-authors on initial joint trauma system clinical practice guideline for prolonged field care for crush. It was one of the first 4 that we wrote. It was one of the top 4 that the medics identified as kind of one of the things that keep them up at night. And why don't we tackle that first when we first started working with the joint trauma system. And, did a literature search to see, hey, what's been published in the last, let's say 3 years, let's say search from 2020 onward. There's a really nice review article that I sent you. I don't know if you can attach that to the podcast, the link. Our guideline, our clinical practice guideline said, put a tourniquet on first before you free the casualty, because it could, stop the release of all of the toxins that are built up because you're not getting any circulation. You've got muscle damage, releasing potassium, lactic acid, myoglobin, that is just sitting in the venous system being trapped from entering the circulation by the crush, and then you remove the object, and all that stuff floods back in. We call it a reperfusion injury. we see reperfusion injuries all the time, and heart attacks when we open up a blocked artery, and in vascular patients, the same thing when we open up a blocked artery, minus usually the myoglobin, the muscle damage protein. There's an argument to be made for that. Two of the societies that really do weigh in on crush, from a disaster response standpoint, don't recommend it. And their rationale for not recommending it is the common thing that we see with tourniquets is you put them on and they get forgotten. Mm-hmm. And that by putting them on before you free the victim, and then, not expeditiously reassessing whether you actually need it or not, say within the first hour or 2 hours, they get left on and they cause unnecessary, nerve damage, and potentially even limb loss of a limb that was salvageable. So I think this is probably something we should reassess when we look at rewriting the clinical practice guideline, which we do. They are living documents. I don't know. I think, what would my advice be? If you really have no monitoring, right? If you don't have an EKG or telemetry, just a one lead telemetry where you can monitor a heart rate and look at, for PVCs or irregular rhythms, and it's a big crush injury. So both lower extremities, the pelvis, a lot of muscle, the gluteal muscles, a lot of muscle that could potentially be crushed and spilling toxic debris that could be released. I would probably argue in favor of yes, but somehow have a protocol to reassess it, whether to take down that tourniquet as fast as possible. And I would also caveat that by saying you don't have that monitoring resource and you have enough people that you can reassess. If you don't have the monitoring resource and it's a real mass cal and you're just going to pull them out and then move on to the next one, I might argue against it because you could be creating a lot of morbidity. The incidence of, cardiac arrest from crush syndrome isn't trivial. It's, I think, 20% was what one of the figures quoted in the paper. And that's probably fatal in a mass cal. But, the incidence of salvageable limbs that need to be amputated is also not trivial. So tough call. I don't think you're wrong either way. I think probably the best thing is, have a plan going in, have a protocol that you train on, and be aware of reassessing the tourniquets as fast as possible. So I don't think I answered your question very well. That's okay.
No, you dodged it successfully. What I'm thinking, so I have a guy trapped. At least in my mind, if he, for some reason, I'm thinking he is hemodynamically unstable, I cannot see where the source of bleeding is outwardly, I'm going to assume he's bleeding on the other side of this object. I would put a tourniquet on and begin, DCR to whatever level I can, give him blood to whatever amount I can, to resuscitate him. That's going to be something that's a known. I don't see anything wrong with doing that. Versus I have a relatively stable patient who does have a giant weight on him. Maybe I don't put the tourniquet on right now. I can wait. Because this is not going to be a rapid extraction. This is going to take a hot minute. And just as soon as you lift that off, does not mean that that's when the reperfusion hits him. It can be minutes later. I've heard upwards of 30 minutes, and now suddenly he's got problems. So you're going to need to not only have all these people help extract him, get him extracted, at least have somebody on standby to watch for the next 30 minutes, make sure that they continue being stable. And if that stability changes in any way, their mental status changes, their pulse feels weird, their chest starts to hurt, their whatever, any kind of negative thing, I would say hurry up and put those tourniquets on, like time now.
At that point though, I think the genie might be out of the bottle, right?
Okay.
So I think by the time you're experiencing symptoms of reperfusion injury, you are perfusing, right?
Yeah.
So that means two things. And number one, it means you probably have some intact perfusion in the leg, right? Your blood vessels aren't completely damaged and the leg might be salvageable. If at that point, then, you've determined to the best of your ability that they're not bleeding, this really is crush syndrome with unstable arrhythmias. At that point, I think you're better off treating crush syndrome because I think you're too late with a tourniquet.
Okay.
And another factor that we haven't talked about too is what's the amount of time between the incident and your response, right? Because if you're Johnny on the spot and you're there within minutes or an hour, then instability is probably one of two, is probably more likely traumatic bleeding. It could be, some early stages of crush syndrome because you've got some perfusion that's getting past the crush or going around the crush, the site of the crush. But if it's, 6-8 hours later, I mean, it could be straight up dehydration, right? The patient, hot environment, 6 hours in the sun, panting, sweating because you're in pain, tachycardic because you're in pain. You could well be dealing with just straight up dehydration. The good thing is that the treatment for crush syndrome and the treatment for dehydration is the same. You give them, fluids, ideally IV or IO fluids. But it makes it a little harder to figure out whether this is bleeding or not.
Right.
Yeah.
Yeah. I mean, yeah, you're absolutely right. So, from the outset, the guy is still pinned. Obviously, you're getting access of some sort, whether that be IV or IO, because like you said, they could be dehydrated. It's going to be a lot more difficult to get IV access when their veins are flat. So potentially you need to do just an IO, get fluids started, rehydrate them at the minimum, start rehydrating them. And then, if I didn't put the tourniquets on, or maybe even if I did put the tourniquets on, do I go ahead and start hitting them with a bunch of fluids, trying to get that urine output up?
I think that, lower extremity crush injury, one lower extremity, both lower extremities, pelvis, yeah, for sure. You're going to want to start hitting them with fluids. I think oral rehydration is fine for this too. If they can drink, they, give them oral rehydration. Here's where, if you do have, portable ultrasound, smartphone based ultrasound, practice putting IVs in with that, because in your patients who are hypovolemic, I had one my last shift in the ICU that we couldn't get any IVs by palpation, but we could get them pretty straight away, IV guided, and potentially even an EJ, an external jugular, because if you can get to the head, and they can turn their head, if ruling out a C-spine injury, that's not a bad idea either. So practice those if they're within your scope of practice. But I'm a big fan of ultrasound placed IVs.
Yeah, I mean, I found that they work really well for more deep veins. I find like the peripheral veins, it's really easy to kind of squish the vein down with just the weight of the probe.
Yeah, I'm thinking like a brachial or an antecubital, more distal to that, like on the hand, probably not. But we get those. We have an ultrasound IV team in the ICU, and those are the ones they usually go for. Antecubital or brachial, and like I said, pretty easy skill to practice. You can do your whole team when you come back from PT; they'll love you for it.
Right.
And they'll be relatively hypovolemic as well.
Yeah. Hey, it's a win-win.
There you go. Good training.
Yes, absolutely. Okay, so how much fluid, how fast? I know in end state, you want that 100 to 200, maybe even 300 cc's an hour. I've heard anyway. And, I mean, am I bolusing this? Am I pressure infusing this? Or do I just let it run?
If you have a good access IO, and humoral IO is probably what you're going to get. Obviously, you really don't want to, if they're crushed in the lower extremities, you really don't want a tibial IO because that's just going to flood into the tissues.
Right.
You have no idea whether those vessels are that you're feeding with a tibial IO or even patent or not. But if you have a IV or a humoral IO or a sternal IO, a liter an hour, probably to start with, if you have the supplies. The best fluid to have the best fluid to use is the one you have. I'm not going to make a recommendation based on that. There are some people who say, don't use Ringer's lactate because it's got potassium in it, but it's got a trivial amount of potassium and it's got a trivial amount of lactate as well. And the lactate, anyway, that's a whole nother rabbit hole. The best fluid to use is the one you have. Drinking the same thing, try to get a liter. And it was interesting reading this latest paper that I read for the podcast. They were saying, hey, if you can get 50 an hour, you're good. So yes, maybe with rhabdomyolysis, we do want those high urine outputs, but just some evidence that the nephrons are working, that the kidney is working. 50 an hour, liter an hour, probably to a max of 3 to 6 liters a day, depending on, your casualty, how big they are. Do they have underlying kidney problems? Do they have underlying heart problems? Because there's a risk with fluid resuscitation and crush, just like there is in burn, of causing abdominal compartment syndrome. And that is a complication that in this, austere scenario would be fatal. They would need a laparotomy and a dirty laparotomy in the field, and an earthquake or a building collapse or a blast is going to be fatal. So, go hard early, get the urine going, and then back off.
Yep. Perfect. So another thing, just assuming, I mean, honestly, you can't even assume that people have the ability to monitor the heart with an EKG. Even the one leads, which are relatively cheap and easy to pack. How do I recognize for certain that this patient is getting an influx of that potassium? I know the classic is like a peak T wave, but I've also read that doesn't always happen.
Well, there are two things that are going on with the heart in crush syndrome. One is the effect of potassium, which, on an EKG will cause a peak T wave. It'll also cause PVCs, premature ventricular complexes. So if you can get a pulse and it feels really irregular, it's thready, and then you feel a big beat, and then it's thready again, you feel a big beat. Those are PVCs probably until proven otherwise. On a monitor, I would be concerned about that. And then, like I said, peak T waves, and then, you're going to deteriorate into a ventricular arrhythmia, VTAC or VFib, which will probably be, you'll probably just lose a pulse. To be quite honest. And at that point, you're doing CPR and, kind of following that H's and T's algorithm in ACLS. Everybody hates that on final exam day, but it's there for a reason. Hyperkalemia, and then you're hitting them with your calcium, insulin and dextrose if you have it, albuterol if you have it. I think teams that respond to disasters probably have pre-packaged kits for crush with monitors, with at least simple one lead monitors, with calcium, with nebulizers, et cetera. Military units may not. But those are some of the considerations. And honestly, just a lot of fluid will help ameliorate. If you have nothing else, calcium and a lot of fluid is going to help. Now, the second thing that's going on is lactic acid, because lactic acid is building up downstream of that. And lactic acid has its own effects on the heart, causing, problems. Both the conducting system in the heart doesn't like an acidic environment, and the contractility of the heart doesn't like a acidic environment, and the contractility of the blood vessels that maintain your blood pressure doesn't like an acidic environment. So you're going to have, just from acidosis, a vasodilatory shock, decreased cardiac output, cardiogenic shock, and potentially unstable arrhythmias. And that's where sodium bicarbonate can be your friend. And again, that's something we didn't recommend in the CPG, because I think we were looking at it more from a potassium myoglobin standpoint and not so much from a lactic acid standpoint. But I think when we look at it again, we should train our lens a little bit more on the lactic acidosis component of crush syndrome. And I like the recommendation in the emergency medicine paper, that talked about if you're concerned for lactic acidosis, unstable patient, you're concerned for acidosis, put 150 milligrams of sodium bicarbonate in a liter of saline. And use that as your resuscitation fluid instead of straight crystalloid.
Okay. I want to say usually it's in milliequivalents. Is that correct?
That could be right.
Okay.
I'm not looking at the paper, and
that's okay.
Every once in a while I mess up my units, but I always check before I dose them.
Yeah. So essentially
3 amps of sodium bicarbonate.
Yeah, 3 amps.
It's 50 milliequivalents per amp. And you 3 of those. And I've been doing some training in the field with some of the military units, and I'm encouraging them to pack at least 6 amps in their loadout, because you can use it in crush. You can improvise hypertonic saline with it for TBI, and you can treat acidosis with it. That's severe acidosis that's depressing cardiac output and vascular tone. So, and it's shelf stable, and it's portable.
Yeah, absolutely. If we can just finish up with the calcium part of it, and I definitely want to jump back into the sodium bicarbonate. So the recommendation, 10 mLs of calcium glutamate or calcium chloride, those two things are not created equal. So is it 10 mLs of gluconate and like 3 cc's of chloride, or just give it what you have?
Honestly, we just give a gram of calcium, and it doesn't really matter which one it is. I know they're not equipotent. I think, again, the best calcium to use is the one you have. Okay.
And what kind of end state am I looking for? Is it just kind of resumption of a normal rhythm? May I have to give more if it's it's a really bad crush? Kind of what are my triggers?
Yeah, you may have to give more. The one caveat to giving calcium is it's got to be a slow. If you're going to put it in a syringe and push it, you need to do it slowly, because if you slam it in, if you just push the plunger, I don't know if people can see my finger. If you push the plunger like that, you can actually trigger arrhythmias. So, I like a nice slow, like a cc, count to 5, another cc, count to 5, another cc, count to 5, even in code situations in the hospital or unstable patients where, we give calcium like water in the cardiovascular intensive care unit, because the heart muscle loves calcium for contractility, and you can really back yourself down off some vasopressor doses just by giving people calcium. You can watch their blood pressure go from 60 systolic to 130 systolic in one push. You do have to repeat it. You would have to be prepared to repeat it. Your indication to repeat it is they become unstable again. It worked, then they become unstable, then you push it again.
Okay. Is there any time period I mean, I know the body does not respond like, oh, I've received 10 cc's, so now I'm going to respond like this.
It's hard to tell.
Yeah.
At some point you will have enough calcium in your body, usually within 1 or 2 grams. I rarely push the third. Maybe 3. I don't think I've ever pushed more than 3 in an unstable patient. Now, mind you, our patients are not crush patients, so I can't speak to that. But there are risks to being hypercalcemic as well. So you want to give enough to stabilize the myocytes in the heart. I'm going to give enough to stabilize the contractility of the heart and the blood vessels, and then probably stop. Then if they're hypotensive, you got to be thinking, well, are they in shock from hypovolemia? Are they becoming septic? Are they in shock from blood loss? What else could be going on?
Yeah, absolutely.
I'd say beyond a couple of grams, you probably need to be thinking what else could be going on.
Yeah. Yep, absolutely. Jumping back to the sodium bicarb. So I remember way back when we talked about sodium bicarb and how it doesn't really push the needle one direction, alkalotic, that much. So is this something that I'm just going to have to continue giving to maintain that?
Yeah.
What clears?
Bicarb is interesting. There's a lot, I don't think you'll ever find a paper that will say outcomes are improved with sodium bicarb. And you'll find a lot of people who will say, don't give it based on the literature, don't give it based on the fact that it breaks down to, water and carbon dioxide. So you trade a metabolic acidosis for respiratory acidosis. I'm just here to tell you from personal experience, and a lot of my cardiovascular intensive care friends are here to tell you from personal experience that in a jam, when the pH is 6.9, 7, 7.1, and the patient's blood pressure is in the tank and they're maxing dosing of 1 and 2 and 3 vasopressors, that it can turn things around. And you're not trying to affect you're not using sodium bicarb to cure them, right? You're using sodium bicarb to buy time for the things that will stabilize them to work. And that's it. And if they don't respond to it, if you get their pH to 7.3 and they're still sick as heck and unstable, okay, maybe they're now either in irreversible shock or they have a shock mechanism that you haven't diagnosed that you need to look for. But, if you get them from 7.0 to 7.3, the pressors will finally work because, one lesser known fact is that all your catecholamine vasopressors, phenylephrine, neo, norepinephrine, levofed, epinephrine, epi, all of them are relatively ineffective at a pH below 7.1.
Yeah.
And so if you just increase the pH and let the pressors work, then you can, use more guideline-driven therapies that are associated with good outcomes. So that's my take on it. I've definitely changed my practice a lot since I've worked with unstable hearts. And, I definitely, and would welcome comment, from other people on and criticism, but that's Doug Pell's take on sodium bicarb.
No, perfect. And I've always just found, the body wants to do something. Like in this case, the body wants to get rid of the potassium. If you can facilitate the body getting rid of potassium, in this case, the fluids, and then you can stabilize the body long enough that it can do the thing it wants to do, outcomes are probably going to be better than me diving in with my 1 year of medical education, just making things normal.
Right. Like I said, back at the beginning, we said complex problems are recipes, not ingredients. If a patient is really bad and getting worse, you probably have minutes to no more than an hour to arrest that slide, or they become, irreversibly shocky and they're going to die. So, and throw something at them and see if they respond. See if you can walk them back off that line from decompensated and to irreversible shock and get them back more in that decompensated, heading toward compensated territory where your other therapies will take over. And then you're done. I'm not giving bicarb, to stable patients. I'm doing it to patients where, I'm just about out of Schlitz. Or, our team is just about out of Schlitz. Let's see. And some, not everybody will respond, but some people do, and then the situation is dynamic, right? Then you have a different patient. You have not an unstable, getting worse patient. You have a sick, stabilizing patient who's getting better, and then you can go from there. And you're probably going to have to do different things.
Right. Absolutely. Obviously, I think after we have dealt with this crush syndrome, it's going to be a hot minute before you're actually done dealing with crush syndrome, I think, depending on the potassium load. And you're not going to know that until you start drawing labs to try and figure that out. So we're just essentially stabilizing things until we can get them to someone far smarter. I'm going to give them to you, Doug. After once we've gotten on this train and we've got a stabilized patient, I believe essentially we're dealing with essentially just wound management after that. So, your antibiotics, irrigation, nothing crazy because we have a potentially unstable person. So surface things to not rock the boat too hard.
Yeah, antibiotics are key. If you've got open wounds, you're in a dirty environment, you've got all sorts of things, grandma ertapenem, and then you can forget about it for 24 hours. And reperfusion injury, it's generally a phenomenon of hours to, I would say no more than a shift, to put it in hospital terms, 12 hours. We see big heart attacks, where like the left anterior descending, proximal occlusion of the left anterior descending artery gets opened up. They come, because they had a STEMI, a complete occlusion. They will come to the ICU afterwards because we want to monitor them for reperfusion injury for at least a shift. And if it happens, you're right, it doesn't happen immediately. It can happen hours later. And then, probably the storm's going to go on for 4 to 6 hours or so. And then by the time morning comes, everybody will be like, why were you so excited last night? And it's like, that patient looks great now.
Right. So just, if you wouldn't mind, I would like to just kind of run through what I had planned before and see how far off I was. So, have a crushed patient, you do your T-Tri-C, life threats. He doesn't have any. I am actually just dealing with the crush. If they're hemodynamically unstable, I planned on putting on, tourniquets on the lower extremities because every crush syndrome is always the lower extremities in every scenario I've ever had. And now, once we're at least ready to move, I had planned on just tightening him down preemptively because I am assuming that he's probably going to bleed once the pressure gets off. We extract the patient. It's still crush syndrome. I'm just have a mobile crush syndrome that I can now take to where I have more resources to bring to bear. We get them to this place. We start with monitoring. I would have already had IV access already because of at least pain control, potentially antibiotics. I need access, probably multiple points of access. Get some kind of monitoring on. Now let's start dealing with these tourniquets. Can we remove them? Can we, I know that there's probably going to be some kind of reperfusion injury, but I don't want to have to deal with it in an emergency. I'd rather deal with it when I'm more prepared, I have more resources, etc. I have my fluids going. I have my urine output higher, like we said, maybe 30 to 50, potentially upwards 100 to 200. We start reducing these tourniquets. I think ideally would be at one at a time. And I'm monitoring this patient looking for essentially anything outside of normal. If there is something outside of normal, that's when I'm starting to give my calcium, slow push, have it already pre-drawn 10 cc's, start pushing slowly, watching that EKG, watching my patient, watching his hemodynamics, making sure that things don't go completely out of whack. And I'll keep giving that until I have a stable sine wave, or not sine wave, a stable, sinus rhythm. Okay. Fluids are going. Essentially, I don't know what to do after that. I don't know if I don't have assuming I don't have an I-stat to tell me my potassium is too high, assuming I can achieve a normal sinus rhythm with my calcium. I don't know, do I need to still give albuterol and raid the pharmacy for insulin and D50?
Yeah, so a couple things with that. If you put that tourniquet on, I still think you need to be getting them to that place where you can stabilize them and monitoring them and reducing those tourniquets within a couple of hours max.
Yes.
And if you can't, I think you and your team need to have a discussion going in about, do we want to do tourniquets first for these big lower extremity unstable patients, and run the risk of, unnecessary amputations, at the expense, at the benefit of, minimizing cardiac arrest, or not. I can't give you an answer one way or the other. I think there's literature and there's guidelines that favor both. Your team just needs to have a plan, and ideally the plan gets them to some place where they can be monitored and you can reduce them quickly, and you can sort of have your cake and eat it too. The second thing is that once you get them to that stable place and you start taking down the tourniquets, if they become unstable, that's when I would switch my fluids to a bicarb solution, because you don't know if they're unstable because of potassium or because of lactate. And the bicarb is going to help with your lactate, and it won't hurt with your potassium.
Yep. And of course, I'm going to expect end-tidal, if I'm monitoring that, to climb. That's normal. It eventually will come back down on its own.
Yeah, if they have spontaneous respirations and you create a respiratory acidosis, they're going to breathe that off too. So again, I'm not sure what all the fuss is about, but like I say, if they're on ventilators, we up their respiratory rate. We check a blood gas and we up their respiratory rate. If they're in the field, you put an end-tidal on, and if it's climbing, they're probably going to breathe it off spontaneously if they're breathing. And if they're not breathing spontaneously, you're probably criking or intubating them, and then you just up your respiratory rate.
Right. Yep. That's a natural thing. Just expect that it will happen, so you don't freak out and start doing other things that you shouldn't be.
And honestly, with 3 amps of sodium bicarb, it's not going to happen. If you get to like 6, 9, 12, okay, that's when you really start seeing it. But but your first 3 amps, I think those are kind of almost a gimme.
Okay, perfect. So we start seeing any kind of changes. I would assume essentially assume once you start releasing those tourniquets, everything that you see as a change has to do with you just removing those 2 tourniquets. Right? We start the sodium bicarb drip. You just open it up and let it run, or do you just drip that in over? Open it up, let it run. Small bumps of my calcium, trying to get things back to a more stable state. And then now you have control.
Yeah. Now you have acute control in a very resource limited setting, and hopefully you're going to get less resource limited as you hand that patient for, this is obviously going to be somebody who gets triaged to urgent. And so hopefully urgent gets them, to a higher level of care sooner rather than later.
Right. Because like you mentioned, I have what essentially I have. There's no run into the pharmacy. And you should be able to plan that out. Like, hey, I have 6 amps of sodium bicarbonate in my crush kit. I have, 3 to 6 grams of calcium in my crush kit. Hey, if this calcium is only lasting me, 10 to 20 minutes, because of the patient's condition, you can kind of start planning this out. I can only hold on to this guy for so long.
Yeah, and you can only hold on to this guy,
Yes.
not these guys or these people. Right. So that's a single entrapment, and hopefully everybody else doesn't have major crush injuries. You did make a good point earlier. You kind of rolled off your tongue where you said, all the scenarios I've had are lower extremity crush, but it is really important. The muscle mass necessary to generate crush syndrome really is in the pelvis, the gluteus, and the major muscles of the upper legs. It's rare, bordering on vanishing, that an upper extremity entrapment is going to buy you significant crush syndrome, reperfusion injury.
Okay, so essentially we're just dealing with almost a blast injury. You're more worried about perfusion of the limb and wound management, exsanguination, fractures, open wounds, antibiotics. You know the deal. Perfect.
And we haven't even muddied the water with, burns if this is an explosion. Yes. So let's not go there.
Yes. I would like to ideally, I have one casualty. Let me focus on this one guy. I think you're dealing with mass casualty, super mass casualty. Like in my world, with what I have carried, like we are in a completely different ballpark, and we're going to triage hard. So, with that in mind, like I'm focusing all my energies on this one patient, walking him through this crush syndrome. Is there anything else that I've missed that it really is important to this? Like, when do I decide to do the albuterol or the insulin and D50 or any other technique?
Well, if they're continuing to have cardiac instability and, again, you're not sure if it's potassium or lactate, you sort of treat for both. You're giving them the bicarb, you've given them calcium, which is, part of the algorithm for cardiac instability due to high potassium. But then, you do the insulin and D50 or insulin and dextrose. It's usually 10 units of insulin and an amp of D50 is what we do. Okay. But would I just give those things, or hey, if you're pushing calcium and you're not seeing great effects, if they're unstable, you bet you're giving them.
Okay. Okay.
Because there's, so risk versus benefit, right? So,
yes.
If you give insulin and you don't give dextrose, okay, there's a big risk. You could crash their blood sugar and they could arrest from that. But, if you give them, insulin that drives their blood glucose down, 100 points, and then you give them, 100 points worth of dextrose, then, net neutral, you haven't done anything. But what you have done is the insulin is moving, that potassium into the cells, if it's indeed there, at least temporarily, and it's, an hour, a couple hours, and if they have competent kidneys, their kidneys are going to help you out, removing the calcium. You just need to get it low enough that they don't arrest, while the rest of the body catches up to help metabolize it. That's the same principle with albuterol. Albuterol is tougher, I think. Insulin's not easy because it needs to be refrigerated. Albuterol is not easy because it needs to be nebulized. A couple of. Now you can make you can MacGyver a nebulizer.
Yep.
Well, only if you have an airway. Sorry.
Yes.
You have to have a crike.
Well, if you don't have an airway, we don't have to worry about crush.
But if they have an airway, an endotracheal tube or a crike, you can MacGyver a nebulizer by putting a metered dose inhaler in a 60 cc syringe. Take the plunger out of the syringe, You get the syringe, you pull the plunger out, you put the meter dose inhaler in, with a tip down toward the tip of the syringe. Yes. You put the plunger on top, you stick that in the end of the airway, and you mash down on the plunger, and it aerosolizes that down the airway, and it acts as a makeshift nebulizer.
Yep. No, I've definitely done that. Keep in mind, you're going to have to keep puffing with that. And just keep in mind also the crike, the tube, the plastic is going to absorb some of that. So you're going to have to probably go a little bit farther as far as numbers of pumps. Make sure you're getting that.
You want to hit it as hard as you can to give it as much force to get past the plastic. But it's still, it still beats, doing a metered dose inhaler, and most of it's going in the back of your mouth.
Right.
Like a nebulizer. And trying to get a crush victim to actually inhale a albuterol neb while they're in pain and not, breathing shallow because they've got broken ribs is, you're basically wasting it. It's just going out in the back of their mouth. Yeah. So if they don't have a definitive airway, you really need a nebulizer, or you're just wasting your time. Yeah. If they do have a definitive airway, you can do pretty darn well with the 60 cc syringe improvised technique.
Okay, perfect. Is there anything else that I've been missing out of my plan?
No, I don't think so. I think you're good. I think you're
perfect.
Good. We saved the one guy.
I saved the one,
or the one we saved the one woman, child, man. But right. Mascal, it's a whole other story.
That's a completely different story.
Yeah.
Cool. Well, thank you, Doug. I really appreciate you coming on.
Yeah, you're welcome, Dennis. Always great spending time with you, and happy to come back anytime.
Perfect. I definitely will.
All right. Take care, buddy.
That's it for today's podcast. Make sure to go to our website, www.prolongedfieldcare.org. Check out our free downloads and a ton of other helpful information. Grab a bag of our fresh roasted PFC coffee, links in the description below, and stay on the bleeding edge of combat and austere medicine. This is Dennis for the PFC podcast, out.